Hi, I'm Dr. Ben Weinberg, a GI medical oncologist at Georgetown University in the Ruesch Center. I'm here to discuss a few very important studies highlighting pancreatic cancer that just got published within the last few months in 2025. First study to highlight is the Tribeca-1 study. One of our colleagues, Dr. Marcus Noel, is a co-author on this study that we did have open at Georgetown. This is studying a very interesting drug called eraspace, which is an old drug called asparaginase, but encapsulated in red blood cells, so it's sort of administered like a blood transfusion. So a new formulation of an old drug that seems to be easier to tolerate than free asparaginase. And in this study, patients who had metastatic pancreas cancer with prior progression on one prior line of chemotherapy were assigned to second-line chemo, either gemcitabine, nab-paclitaxel, or nanoliposomal irinotecan, 5-FU leucovorin, and then they were randomized to receive eraspace or not. Of note, this was a negative study, so the median overall survival was 7.5 months with eraspace and 6.7 months without, with a hazard ratio of 0.92. Progression-free survival, pretty similar, 3.7 versus 3.4 months, and response rate, again, similar, 16.1 versus 12.5 months. Of note, the group that was assigned irinotecan-based chemotherapy did have a slightly numerically longer median survival, 8 versus 5.7 months, with a hazard ratio of 0.81, but this was not statistically significant. So unfortunately, this drug really has not been further developed in this space. Another study to highlight is the PASS-01 study. This was a study trying to establish whether we should be using our triplet regimen, FOLFIRINOX, or our doublet regimen, gemcitabine, nab-paclitaxel, in patients with de novo metastatic pancreatic cancer, so diagnosed with metastatic disease. Importantly, they excluded patients with germline BRCA1, 2, or PALB2 mutations who we know benefit from platinum-based chemotherapy. And while we think of FOLFIRINOX as generally having a higher response rate compared to gemcitabine alone, in this study, the response rate was actually quite similar, 28.6 versus 30.4% with gemcitabine nab-paclitaxel. Median overall survival also quite similar, 8.5 versus 9.7 months. Progression-free survival, 4 versus 5.3 months. This study also looked at sequencing these tumors to try to delineate them into a more basal-like tumors that tend to respond better to taxanes, and classical that we think may respond not as well to taxanes. And in terms of progression-free survival, this was true. The basal-like progression-free survival was 3 months with FOLFIRINOX, but 5.5 months with gemcitabine, nab-paclitaxel, a or taxane-containing regimen. The classical subtype, it was the opposite. It was 6.3 months with FOLFIRINOX, 5.4 months with gemcitabine, nab-paclitaxel. But importantly, when they looked at median overall survival, numerically, gemcitabine, nab-paclitaxel was higher for basal, which was 7.5 versus 8.9 months, and classical, 9.7 versus 13.9 months. So we need to kind of get out of our heads that gemcitabine, nab-paclitaxel is somehow inferior. It was compared to NALIRIFOX, but compared to FOLFIRINOX for folks with de novo metastatic disease without germline homologous recombination repair mutations, it's a perfectly acceptable regimen, and in some cases might be superior to FOLFIRINOX. Another study to highlight out of Europe was the CONCO-007 study. This was looking at unresectable pancreas cancer without metastatic disease. Patients all got induction chemo, either FOLFIRINOX or gemcitabine for 3 months, and for those who did not have disease progression, they were then randomized to continue the same chemo or get chemoradiation with concurrent gemcitabine chemotherapy. And they were looking predominantly at the overall R0 resection rate, so how many patients were able to get to surgery and have negative margins. With chemo, it was only 18%. With chemoradiation, it was 25%, but that difference was not statistically significant. What was a little bit slightly significant was that those who did get to surgery, if you look at just that population, the R0 resection rate was higher. It was only 50% with chemo. It was 69.4% with chemoradiation with a p-value of 0.04. Importantly, there was no overall survival difference whether folks continued chemo or got chemoradiation. So we often use radiation to try to get patients who are unresectable to surgery. This study definitely supports that, but of note, it was overall still a negative study. It didn't seem to matter whether you continued chemo or got chemoradiation with gemcitabine. Finally, the PREOP-PANC-02 study out of the Netherlands looked at what neoadjuvant therapy we should use for patients with resectable and borderline resectable pancreatic cancer. Patients were randomized to either 8 cycles of FOLFIRINOX followed by surgery, or neoadjuvant chemoradiation with gemcitabine for 3 cycles, followed by surgery, followed by an additional 4 cycles of adjuvant gemcitabine. And importantly, this study was also negative. The median overall survival was essentially the same, 21.9 versus 21.3 months with chemoradiation, hazard ratio of 0.88. So this study supports giving neoadjuvant therapy. Everybody on the study got some form of neoadjuvant therapy, but it turns out it may not matter as much whether it's FOLFIRINOX or chemoradiation with gemcitabine, which is not a regimen we use that much in the United States. So it supports, again, giving treatment, especially for borderline, but also for resectable pancreatic cancer, giving some form of neoadjuvant chemo or chemoradiation.